when I first got into the field, there were people that could be hospitalized for months and months. But of course, people still kill themselves in psych hospitals. But I would say, to be fair to this whole debate or discussion, I really like that model. I like being hospitalized patients and, really breathing a sigh of relief and saying, okay, at least they're in a protected environment. At least there'll be nurses who are doing 15-minute checks, that I have some objective reason to feel personally a sense of relief, that they're safe now, they're in sanctuary, they're in asylum in the noble sense of the word, and now we'll really work on things, and when they get discharged, I love that model. So maybe it's just the pragmatist in me sort of saying, well, those days are gone, but it's left a legacy where contemporary clinicians are really stunned when they go to try to hospitalize somebody. And I did a workshop a few months ago where a clinician told me about a 17-year-old that she was working with, and she was very worried about him, and he had a gun at home, and he had given away prized possessions, all these sort of termination behaviors that we are concerned about. And so he was in her office, and she was calling the insurance company to pre-certify him. He was amenable to going to the hospital, and clearly felt that he was in imminent danger. And the insurance person at the other end was like a utilization review person or something, and said, well, does he have bullets for the gun? She said, I don't know. I guess he actually wasn't in her office, but she was trying to effect this hospitalization. And she said, I didn't ask. And they wouldn't pre-certify him because she didn't ask whether he had bullets for the gun. So here she is then pushing for this hospitalization because we're seeing increasingly imminent ideation without an attempt behavior may not be enough to get somebody into the hospital. You have clinicians who are going to that well and making the strong case for their patient to be able to go to the hospital and then can't get them in. And then what? It creates a big problem for the field and for society, because for literally hundreds of years, we had a way of thinking about vulnerable suicidal people. And while it may not ever have been a great model, it meant to be a benign, enlightened approach, that these are vulnerable individuals that need to be protected from society. And the original notion of asylum was actually quite enlightened, and it was a really beautiful thing. And in our data, as I suggested earlier, we clearly know that suicidal people crave escape. So it was actually a pretty intuitive and neat idea to think we can deliver or provide sanctuary, a place to escape your suffering. And I think in the best sense, that's what inpatient care was able to accomplish to some extent. What I now argue is can clinicians find an approach, a philosophy, a set of techniques where the outpatient therapeutic alliance is asylum?